you. Good afternoon, everyone. Am I audible?
Yes.
Okay, thank you, ma'am. So today's topic is regarding amyloid imaging. So in our Vayomanasa program, we have been talking about Alzheimer's, dementia from multiple sessions we have had. So today's session is mainly towards amyloid imaging. So what is causing this Alzheimer's dementia? How is it caused? And how to detect it? So we are going to see briefly about all these topics. So coming to introduction to Alzheimer's disease, actually we need not introduce you people, but still it's a dementia. It's one of the leading cause of dementia throughout the world. It's a progressive neurodegenerative disorder. It affects memory, thinking and behavior of an individual. So overall, as per the current statistics, there are around 50 million people affected worldwide with Alzheimer's disease, and it's a leading cause of dementia. So how is this Alzheimer's disease? What is the cause of it? You will be having these questions. So mainly it is said that it is because of formation of amyloid plaques, accumulation of amyloid beta proteins inside our brain. So other than that, there are various other theories how our nerves get damaged. Another cause may be due to neurofibrillary tangles. These are aggregates of hyperphosphorylated tau protein. So these two are proteins. Other than this, there can be neuroinflammatory causes which directly damages our brain neurons, etc. So coming to the role of amyloid in Alzheimer's disease, like it is a central to amyloid hypothesis that causes Alzheimer's disease, and also plaque disrupt cell. These amyloids, I will explain you in the future slides. How do they aggregate? How do they damage our neurons? And at the end, neurons are the one which are suffering.
So talking is not audible. I message them, but they can hear on. They're not replying. GP said it's not audible. No.
Am I audible? Can anyone tell?
Yes,
Yeah.
yes, sir.
You're audible, sir.
From Vayomanasa,
We can hear you.
So I thought it's someone different. I thought it's PT sir or someone.
We can hear you.
Okay, thank you. So moving forward, so here you can see. So my cursor is visible, I think. So these are normal proteins that are there in our cells, in our brain tissues. So amyloidogenic pathway. So when these proteins are divided by the alpha secretase, they divide, and these protein debris that are left, they are excreted from our body. Whereas in amyloidogenic pathway, the way these proteins are degraded is different from the non-amyloidogenic pathway. So here you can see there is alpha secretase enzyme, and here there is beta secretase and gamma secretase. Basically, this is instead of taking one path, the brain or our body is taking another path. When this occurs, to a certain level, these proteins will also be excreted from our body. Whereas when it is over the level and they start accumulating in our brain, so once in the form of A beta monomer, A beta oligomer, they accumulate and they come together. One protein comes with another and they starts forming oligomer, fibrils and plaques. When these plaques are formed, what do they do? In the right side image you can see they start doing some anatomical and chemical changes where more calcium will be coming into the neurons, and this causes neuronal cell death by apoptosis. So when this happens, the left side of the image shows us the healthy brain, where the cortex, the outer grayish, darker gray area is our cortex. These part of our brain gets degenerated. This degeneration is because of neuronal death. So when this is there, why this amyloid has to be there? Is there any use in our body? Yes. So normal metals and when we ingest a few metal particles into our body, these helps in metal chelation and excretion. They are also play antimicrobial functions in our body and cholesterol transport regulation, blood vessel repair, and antioxidant functions. These are other functions apart from their role in our brain. So so this is the underlying pathology and amyloid related to amyloid. So how do we traditionally diagnose Alzheimer's disease or Alzheimer's dementia? The first thing is clinical evaluation. We speak to the patient, we speak to the caretaker, and do cognitive testing, bedside testing. Then also in detail we do neuropsychological assessment to know the cognitive level and whether there is reduction in level. And there are structural in the sense it is the way our brain currently is. It can be assessed using MRI and CT scan. So these MRI CT can help us in identifying brain atrophy and other changes. The atrophy is what I have already shown here. So coming to amyloid imaging, this is the next. Apart from this, is there any other technique in which you can identify amyloid or Alzheimer's diseases? They are gold standard in the sense it is like yardstick. So you can use it. The thing that can be used is biopsy and fixation technique. Or in the sense they will take a part of your brain and they cut it into small pieces and keep under microscope and check whether there are amyloid plaques which are being deposited in our brain. So that is invasive and not ethical. So other technique that are coming up is amyloid imaging. So we are trying to see where are these amyloids deposited, whether they are in particular area, whether how much is in that area, whether it is too vastly distributed. So these can also help us in diagnosing, finding out amyloid and later into diagnosing Alzheimer's disease. So what is amyloid imaging? It's an imaging technique to visualize amyloid plaques, and advances in PET, positron emission tomography, and other modalities to identify these amyloids are also coming up. So this is a way it will be there. So just like an MRI and CT scan, a big machine will be there inside which the patient or the person to be evaluated can be sent, and later due to the MRI technique, the imaging will be produced, MRI or CT, the imaging will be produced, which will be assessed. So commonly used tracer. What are these tracer? So we have, as I told, there will be deposition of amyloid in our brain. So to tag them, tracers will be used. These are external substances which are introduced into our body, which go and deposit themselves on amyloid substances inside our brain. So through which when we take MRI, they become more evident. Just MRI cannot visualize amyloid. When tracers are attached to the amyloid, then the image becomes clear. So commonly used tracers are Pittsburgh compound B, flutabutapir, flutamidamol, etc. So coming to the tracer used in NIMHANS, it is flutamidamol and NAV 4694. So here we use dosage of 5 to 7 millicurie. Taken up, the patient is taken up for scan about 50 minutes after the patient being given this tracer. So there is no fasting required. Overall scan time, that is after giving the tracer, the patient will be taken up 50 minutes later into MRI chamber. So it will take about 30 minutes inside the chamber. So overall procedure may take roughly around 1.5 to 2 hours. So at the end, we will get these type of images. So as the redness increases, if you want to just understand, as the redness increases, it indicates that there is more amyloid deposit and the tracer has been attached to the amyloid. So in clinical practice, this amyloid scanning or the amyloid imaging helps us to know the amyloid plaque burden in our brain. So previously I told it was we were using clinical assessment, history taking to know the diagnose Alzheimer's disease. now usage of amyloid PET and amyloid imaging has come into the diagnostic criteria. So early, what is the use of this? Why it has to? So till it runs like the amyloid start depositing. Once a level is reached, there will be symptoms in the patient. We can using amyloid imaging, we can try to find out whether the amyloid deposition is before the clinical symptom also. That is early detection and diagnosis of Alzheimer's disease and differentiation from other dementia. That is, as we know, dementia is a umbrella term which includes FTD, frontotemporal dementia, Alzheimer's disease, and dementia, etc. So this helps us to find whether it is Alzheimer's disease that is causing dementia or other disease. So is it like all happy everything? No, it has its own limitation and challenges. The cost and accessibility, it is having a very high cost, and availability, limited availability. As of now in India, there is no available PET imaging for amyloid or Alzheimer's disease. Currently, there is a research project that is going on in NIMHANS, which helps us to avail this facility in Bangalore, in our NIMHANS. So okay, we diagnose Alzheimer's disease and Alzheimer's dementia. So what is the use? What is the use of it? So implication on future treatment. So current treatment targeting amyloid. So what does these drugs do? The amyloid, as I've told, the amyloid plaques will be deposited in our brain. These drugs go and tag themselves just like a tracer. Instead of that, they will tag themselves to the amyloid, and later this is removed by our immune system from our body. So there is removal of these deposited proteins or amyloid in our brain. That is how these drugs act. So there are 3 drugs: aducanumab, donanemab, lecanemab. So aducanumab is going to be discontinued in November. These drugs are currently not available in India. In future, they might be made available, and they have their inherent cost is very high. So we have to see. Apart from the current 3 drugs that are available in the market, there are various, like N number. As you can see in the right side, there are N number of drugs that are being researched into. So that underlying thing is the pathology we know, we have to remove those amyloid. So for that sake, there has been research going on. There are various other approaches apart from amyloid, like tau being targeted or inflammation being targeted. So these are other approaches, but current using amyloid, there are these many drugs that are being researched into. So PET tracers inherently, they also can cause little bit of anything induced into our body. They will have their effect and side effects. So future advances may be into working into better tracers and imaging modalities, the time duration or the cost reduction. These are the targets. So in other potential biomarkers in combination of imaging will also help us to more accurately diagnose Alzheimer's disease. So biomarkers like plasma biomarkers, there have been research into taking just like diabetes and renal disorder to be investigated. Just like that, blood can be taken and blood plasma biomarkers can be researched into. Currently, they are not available. In future, we are expecting. So I think like handling the sensitive diagnostic, and psychological and social impact of early detection, these things have to be noted, because as of now, there is no clear treatment per se. If you are diagnosed, only symptoms are managed, and the amyloid disease, the pathology itself is not being managed correctly. So we need to be more cautious into giving diagnosis or early detection. So this is the overall. So one of the research we are conducting is using this amyloid imaging technique. This has been conducted in our NIMHANS. So this helps us to normalize the data, and future it will be made available to the public. So if anyone is interested to participate, the contact number and email can be used. Thank you. Now we can have questions.
Hello, sir. Can you hear me? Hello, can anyone hear me?
Yes.
Yeah.
Yeah. Sorry. I had a question. So I did fill that form, sir, like that you provided to participate in this PET imaging. I just wanted to ask, how that procedure will be. Like, will there be any invasive, um, uh, stuff taken for screening, or like, how will that procedure be? Sorry, were you able to get my question?
We come.
Sorry, I cannot hear.
Doctor, we can't hear you. You're on mute.
Okay. Sir, I have a question to you. Can I ask you, sir?
Can you hear me?
Yeah, are you able to hear me? Hello?
Hello.
Are you
Yeah,
able? Okay.
guy, yeah,
I
we
have-
can hear you. Sorry, I think the NDA NIMHANS user ID, they are on mute. We cannot hear.
Yeah, but I think Yashwanth, you're unmuted.
Yeah, it's still on mute.
Can you hear me now?
Yeah,
Yeah.
we can.
Yes, doctor.
Yeah. So taking up the first question, whether it is invasive. So the amyloid PET is similar to any other PET imaging being done for any other tracers such as FDG PET or any other PET. So all we'll be putting is a cannula and we'll be injecting the radioactivity. And the rest of the procedure is similar to any PET CT procedure. So absolutely there is no difference other than that the tracer will be injecting his amyloid.
Yes, sir. You are audible. You can ask the question.
So you can go to the next
Okay.
question.
My question is, sir, with regard to the two proteins that you talked about, one is amyloid and the another one is tau. If my
Yes, sir.
understanding,
Yes, sir.
these two proteins, why do they become excess only to the brain? Is there any other part where it can go and also damage the other parts like the brain?
So if you're looking at the pathology as such, amyloid deposition is very common among diabetics, but that is a systemic amyloidosis. The protein deposition there is very different from what is known to cause dementia. So amyloidosis is a very common pathology, but again you can subtype them. Only this subtype of amyloid protein gets deposited in the brain and causes dementia. That is A beta
Right.
protein 42, 43.
Whenever this amyloid gets deposited in the brain, it affects it. And
A
that causes
particular subtype of amyloid only gets deposited in the brain. So, like in systemic amyloidosis, the protein subtype is different.
Is there any method by which we can start consuming less protein which contains this amyloid, and thereby not causing any other side effects of deficiency in protein to the body?
Sir, I have put a slide. These amyloid are required for our body also.
Okay.
If you are not taking these amyloid, they have other mechanisms of protection, like their role in cholesterol and also vascular integrity. These
Okay.
amyloid proteins also play their role in them. So it is not like if we take less protein, the amount of amyloid deposited into our brain will be less. But they have, it is like double-edged sword. These have good role also. If they turn into excess and deposit in particular areas of our brain, they have their harmful role also.
Yeah, by-
Dietary intake and dietary changes has not shown to be so significantly affecting our protein depositions.
Acha, this excess is determined by the biological factors within the brain itself, is it?
Yes, yes.
Okay, okay. Then we have no control as such for the deposition.
No, no.
But I mean by either less taking or not taking or consuming less of that kind of protein which contains mostly amyloid and tau.
No, 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 sir.
No, very good. Okay, thank you, sir. So that means this dementia disease, we have absolutely, however early or however late we get it diagnosed, we have absolutely no external control over it.
The thing is, there is a amyloid hypothesis which we have discussed. Like that, there are other hypotheses also. Other factors also play into their role in these protein deposition, like inflammation and other proteins. So even diabetes, uncontrolled diabetes for longer time, cholesterol level, these other parts also play a role. So if we can control them, the overall burden into protein deposition will be reduced.
Okay, okay.
So Yashwanth,
Yes, sir.
yeah, I joined now only because I'm still in OPD. So the question Mr. Nagaraj is asking is about modifiable risk factors.
Yes, sir.
So we have, I think earlier in our other sessions we have discussed, there are almost well-established evidence is there. 12 risk factors are there, which is kind of helpful to reduce the risk by 40%. So it is not that dementia, we cannot do anything to prevent dementia. There are factors which are helpful. Diet also can be helpful. Healthy diet can be helpful. There are several research that is going on. A lot of people ask about coconut, curcumin, various other dietary supplements. But till date, there's nothing which is absolutely kind of proven that, okay, this is going to help. But in general, healthy diet, which is less in cholesterol, having more vegetables and fruits, these things are less in oil, these things are helpful. Whatever that is good for heart, that is also good for a brain.
They say this, Dr. Sivakumar sir, they say this walnut, almond, and what is it, antioxidant food gives better protein, and then they are also helpful for reducing the amyloid in the.
No, there are so many things. They may be good for many, just not for brain. It may be good for heart also. But one thing what we need to understand is there is nothing like absolute protection, like vaccination. Say whatever good things you can do. Okay, so that is that includes cognitive activity, stimulation, exercise, controlling diabetes, hypertension, reducing depression, and controlling, correcting the hearing impairment. There are like that many risk factors are there. We will have even about dementia prevention. There will be one session because some of the caregivers will be concerned about it. What happens to me because my father is there, my mother is having dementia. Will I get the risk? So this is often a question what we get asked. So we will discuss that in detail in the next session. This session, what Yashwanth has answered is, it is not just amyloid is less, so you can take something diet less and amyloid will be kind of, that can be managed like that. This is one marker which helps us to detect Alzheimer's disease.
Very good, sir.
So that way, we estimate it based on how much it is deposited, where it is deposited. There is a both qualitative and quantitative assessment the radiologists they do. And then by comparing to a normal database, they estimate if it is more than a particular level, then Alzheimer's disease is a likely possibility.
Okay.
So that is the
even while taking the corrective medicines also, will this deposition takes place continuously?
It can happen. It can happen. Still, it can happen. So
It
it's
can
not, there is, as of now, there is no absolute prevention which is possible.
Hmm.
The newer drugs can help in minimizing the risk in terms of conversion to dementia. There are some possibilities. So
Okay,
we will discuss that, sir. I think we can also give opportunity to many people who want to ask so that
Oh,
they
yes, sir.
can call.
Thank you. Hmm.
Thank you very much.
Thank you very much, sir, Professor, sir.
I think there are some chat box questions are there. We can take that up. And Yashwanth, have you responded to that chat box questions?
Yes, sir. Yeah.
Has it been responded? Isaac John has asked about expensive, how expensive is it to amyloid imaging? Have you responded to it or should I
No,
answer?
sir. No, sir. No, sir.
We
So,
haven't responded.
yeah. So coming to the question about how expensive is PET MR. So at present we have started because it's the first in the Indian population we are doing. So at present we are doing through a project mode, and the cost of the imaging will be taken care of by the project.
So usually, what is kind of what we know, it is few $1,000s. So it is Dr. Sandhya, you know the exact cost. What is usual cost in the US?
Yeah,
For
it's
other
around $1,000. But in India, we are planning for a very highly subsidized rate. But since right now we are going through a project mode, I cannot tell the exact cost
that is,
when. Yeah.
So, but given this is something like being done only as part of research at this point of time, there is no cost being charged for this scan as
patient.
part of research.
Okay.
Somebody is okay. Is there a is it
Side effects.
audible?
Is there any? So the next question is there any side effect of amyloid imaging if somebody wants to be a volunteer? So at present, we are not taking any volunteers or any healthy controls. So they should have clinically, they should be evaluated and they should have mild cognitive impairment or dementia to be a part of the study. And the dose of amyloid given is in very low amount. It's in picograms, which is less than which is very a small amount of radio pharmaceutical is given. So there are no side effects of the pharmaceutical part of it. But since it's a PET imaging, which we are using, so there is a exposure to radiation of around 5 millicurie, 5 millisieverts. And so any diagnostic imaging will also, like a regular CT of the brain also would cost 10, would expose a patient to around 10 millisieverts. So this is half of that. So it's 5 millisieverts, because we are doing PET MR and not PET CT. So the radiation is the only concern here. But I think since we are taking only patients who are 40 plus, I don't think that should be, there wouldn't be an issue of pregnancy. So hence it is indicated.
Yeah. So Sandhya, I'll just add here. So one, this is something like not a very new test kind of a thing. PET scans are happening for multiple reasons and multiple indications. In all these things, there are several indications where PET scans are repeated because of clinical indication. And even in research, healthy people are recruited. There are cohort studies which are being done across the globe in several countries, which includes healthy elderly as well as people who are having mild cognitive impairment and dementia. And now PET scan happening over the frequency of either once in 2 years or sometimes even once in a year if it's a patient with dementia, that is being done. So in terms of the dose, what is being given as part of this test, there is no major issues with respect to clinical risk. And any MRI, because it's a PET MRI, whatever is the contraindication for MRI, those things has to be done. And PET as such is not a problem. So I think if somebody would want any clarification, when we actually discuss individual basis, we will be able to answer all your queries, and then the consent form also will have about these issues. So there is no need to be apprehensive about it. Now, Dr. Prerak has asked a question, which is very important. I think we missed it out and then went to the next question. So he has asked about do peripheral amyloid assessment and CSF assessment are in practice of Indian settings. So this is basically the amyloid. What we are seeing in scan can be measured in blood as well as CSF. Usually the CSF, what is the cerebrospinal fluid? That is they'll do a lumbar puncture tap and then collect the fluid, the spinal fluid, and then assess this. Usually this is considered as a gold standard. And we do CSF test for many other things. When we suspect infection, there are some autoimmune changes, we do CSF test. So like that, this amyloid also can be detected through that. Recently, CSF test for amyloid has been launched on a commercial basis. We haven't started using it in our center. We hear that one of the labs they have already rolled it out. I have not practically referred and I'm not able to tell you practical experience, but I have heard that it is available in one of the labs. And the peripheral blood, again, is something which is being researched as to kind of introduce it in a commercial basis. But to our knowledge, it is still not available on a commercial basis. Now, the difference is that what we see in peripheral blood, what we see in CSF, what we see in scan, they're all amyloid, but they have different, there are some differences. It's not exactly the same, the way how we understand. So sometimes this can be complementary, and people in research, they use everything. And clinically, we have not used both the blood and CSF as a routine, but we have done as a research. Because in research, what happens is you collect the blood and then or collect the CSF and analyze it as a group. We don't analyze individual patients as of now, but that facility may come up in future. The advantage of PET is that it is less invasive compared to CSF. CSF, you need to do a lumbar puncture. Peripheral blood, again, we don't know. Again, there are different markers are available. We need to see as to how it translates into clinical use. We are awaiting for a formal approval and launch of this peripheral blood test. The research is moving in the direction, because once that is available, it will be much more cost effective, or it will be acceptable for people. But even if blood is available, CSF will be much more, CSF and amyloid scan will be much more closer. And because that's in amyloid scan, you can also see that over a period of time, how much deposition is actually getting removed from the brain. So that is also possibilities with the newer treatment. So there may be a place for using all three of these things in the clinical practice. It may not, one may not replace the other. There may be different indications. For example, to screen people, normal people, we'll use blood test. For people who have dementia and symptoms, we may prefer using CSF and imaging as a primary modality. So these are some things, these are all newer developments. It still has not reached a regular clinical practice. Hope this has answered. Dr. Prerak, do you have any follow-up questions regarding this? Dr. Prerak, is it okay? Has it answered your query?
It's replied.
Okay. Yeah. So I think we can go to the next question, Yashwanth.
What's the right time to get evaluated? How is this test or scan useful if I already know I have dementia by habitual observations like forgetfulness?
Yeah, it's a very good question. So when is the right time to get evaluated? Now, at this point of time, say it helps more in the early stages. One is that at any stage this can be helpful, but one, if somebody is having dementia in a more advanced stage, one is imaging is less likely to be possible without anesthesia, because they may have some behavioral disturbances. Usually this scan at this point of time, we prefer doing in people who are cooperative. And once the scan, the role of scan is not to kind of test whether it is dementia or not. dementia is still diagnosed by clinical diagnosis. The role of PET scan is for diagnosing whether it is Alzheimer's dementia or other dementia. You need to understand that dementia have many types, and Alzheimer's is one of the types. So, which is the most common. So, why we should test this? Having a specific diagnosis is possible at this point of time. Despite that, we have to acknowledge that there are no easy cure or specific treatments which is available at this stage. There are a couple of medications which have been kind of launched globally, but they are not available in Indian settings and they are very expensive. So, but in future, having a specific diagnosis either in the person or even in the family history will be helpful when early intervention is something which is required with some expensive interventions. So, for example, if the time when we actually have to take these decisions, if there is a family history of Alzheimer's is positive, that also helps the person take decision for certain treatment possibilities. So, at this point of time, the focus is in getting a specific diagnosis of Alzheimer's disease. And it is more for confirmation. Clinically, we may diagnose person as Alzheimer's disease, but a neurologist or a psychiatrist, when they diagnose somebody as Alzheimer's dementia, based on clinical evaluation, 1/3 of our diagnosis can be wrong. Because without biomarker, when we diagnose, we know that people whom we diagnosed as Alzheimer's may not have Alzheimer's. People whom we diagnosed as some other dementia may have Alzheimer's. So in some individuals, they may have two types of dementia also as a mixed dementia. So that is where clinical diagnosis has a limitation because we are not looking at the specific pathology. So this will help in getting the specific pathology. And these are more useful in the initial stages when the treatment are more likely, whether the current drugs what have been launched in globally or any other future treatment that is going to come based on specific Alzheimer's disease diagnosis, they are likely to be helpful in the early stages. So that's how we need to see at this point of time. We don't recommend this for normal people. We don't recommend this at this point of time because people may have deposition of amyloid even many years before the symptoms. We don't diagnose somebody as Alzheimer's dementia based on only positive amyloid scan. It always it has to be correlated with the clinical feature. So if you just go to the scan and then you say, I want to get amyloid test done, and then only based on that, will I diagnose? No, we will not diagnose only based on that. Okay. Is it clarifying your doubt, Ms. Anita?
Yes, sir. It did. Yes, doctor, it did that.
Yes. Thank you. Thank you. So the next question, Yashwanth, can you address this?
My husband is 72-year-old and taking some medications. He is suffering from frontotemporal dementia. If the question is like whether he can participate in the study, if he is like cooperative and able to like be cooperative for 30 minutes, so he can participate. This study also aims at differentiating between Alzheimer's dementia and frontotemporal dementia. So it can indirectly help him to confirm that this is not an Alzheimer's disease. This is a frontotemporal dementia.
Taking the question further, we have had a few cases which were diagnosed as FTD, and on amyloid PET, they have turned out to be AD. Not AD, I mean amyloid positive, indicating that it could be an AD pathology. So at least 30% of the population which has been diagnosed as FTD may turn out to be AD. And they may be a frontal variant of Alzheimer's. So in those cases, I think FTD also can participate in this study.
Yeah.
Oh, thank you so much. This is Sunanda Naik.
Yeah.
For Google form, what you have mentioned here, I have to fill that up for the study, is it? Sample.
Yeah, I think that will help us. That will help us to reach out to you, and then we can discuss offline further about this thing. Okay.
Any contact number?
Yeah, I think the flyer what we have shared, I think you.
Yeah, contact us. Okay. Thank you so much.
Okay. So both Alzheimer's dementia and frontotemporal dementia is, I think, distinguishing between Alzheimer's dementia and frontotemporal dementia is one of the main clinical indication for PET scan. The reason is that sometimes some of the drugs given for Alzheimer's dementia can worsen behavioral symptoms in frontotemporal dementia. So again, we try not to give certain drugs. So clinical overlap can be very much there. Okay. So yeah, I think Yashwanth has answered that question as well as Sandhya, Dr. Sandhya has clarified it further. So
Thank you, sir.
any other, yeah, we have some more questions now.
Read the next question.
Yeah, take the next question. Yashwanth?
Sorry. MRI shows brain cells are damaged or have died. So is this scan to confirm at a second level scan, or this is a replacement of MRI?
So MRI is basically for structural imaging. So we are not looking at here at amyloid pathology directly. So if you're talking about Alzheimer's dementia, in the context of only a diagnosis, till now we were using MRI to make a diagnosis of Alzheimer's, but at when it was almost moderate to severe stage. So, but at that point window, treatments are not possible. Like the present projects and present worldwide, what is going on. So the target population they are looking at is whether we can diagnose amyloid deposition much earlier, even before the cells have died, also clinically called as, the right term would be atrophy. So in such cases, an amyloid PET can predate a normal MRI by at least by 15 years. So that's where amyloid PET plays a role.
I think these things have complementary role. Amyloid scan availability will not replace the need for MRI scan. So both, as Dr. Sandhya highlighted, both evaluates different aspects. And in our center, amyloid and say scan and MRI are done as at a single session. So somebody usually when they diagnose, the first level could be a CT or MRI they might have done. So that means even if MRI is done, this is done for an additional purpose. So it is not going to be replacement. Okay. So the next question somebody, Darshita Varigonda has asked is, should all MCA cases undergo imaging? So generally, mild cognitive impairment is a stage where we consider it's a risk factor for dementia. So any cognitive decline, one of the evaluation is imaging, because there can be many reasons why somebody's cognitive function can decline. And it includes something like a stroke, or a small tumor can be there. There can be brain atrophy, which can help us to explain. There can be collection of blood. So in usual, so as a protocol for evaluation of MCI, brain imaging is definitely included. Whether they have to do amyloid imaging, for understanding the specific kind of risk for Alzheimer's, even as part of MCI, mild cognitive impairment evaluation, amyloid imaging can be considered. And that's when actually the treatment is more likely to be useful in future, when specific treatments are going to be available. So it will be one of the options of investigations as part of evaluation of MCA also. Hope that answered your query, Darshita.
Yes, sir. Thank you so much, sir.
Thank you. Welcome. Welcome. So the next question is Gayatri. Can rivastigmine patch help to delay the progression in FTD cases? So see, rivastigmine is one treatment which is again a symptomatic treatment for primarily to be used in Alzheimer's dementia. We don't have any evidence to say that rivastigmine helps in frontotemporal dementia. Sometimes it can worsen the behavior in frontotemporal dementia. So rivastigmine does not have evidence to say that it delays the progression. These are called as symptomatic treatments. They can improve memory to some extent temporarily in persons with Alzheimer's dementia. But because these are all conditions which is a progressive worsening associated with progressive worsening, in an individual patient, you may not be able to even appreciate that improvement. Because every day and over a period of time, they may are expected to have worsening of memory. So even if I give rivastigmine or donepezil, these are 2 or 3 drugs, rivastigmine, donepezil, galantamine. These are 3 drugs which are approved. And they may be helpful when you compare as a group. But in individual patient, we may not be able to find out whether this drug is working, this drug is helping. So it is often people come and say, I started medicine, after 3 months I stopped because there is no use. It is impossible for any individual patient to identify whether this drug is working or not. So if the drug is not harming, there is no side effect, we advise to continue these medicines till the late stages, wherein giving medications itself is a problem. So these are at least evidence-based way of providing help. But not all dementias, we recommend this. And if somebody has worsening of behavior, it is better to withdraw rivastigmine. Okay. So, and in Parkinson's dementia, again, it can be helpful. Alzheimer's dementia, Parkinson's dementia, and Lewy body dementia. These are the 3 types of dementia where rivastigmine, donepezil, and galantamine, these 3 drugs can be helpful.
Okay. Okay, sir. Okay, thank you.
Okay. I hope that answers your query.
Next question is role of SPECT in dementia.
Sandhya, can you
Yes.
take this question? Yeah.
Yeah. So role of SPECT in dementia. So a few years back, we had SPECT in our at NIMHANS, and they have actually tried in dementia to subtype with SPECT. So I'm not denying that there is no role. But if you're comparing with PET is definitely a better modality because of its better spatial resolution. And ECD SPECT was what was being used earlier to subtype different kinds of dementias. At present in NIMHANS, we are using FDG PET because of its better spatial resolution and better way to pattern analysis is much better. So SPECT for historical purposes is still being used in some centers where PET is not available.
Yes. Hope that answered your query, Ravi. This is one other way of testing, and we have also used it earlier. Right now, we are not using it in our center.
So,
yeah.
Which is cost effective, sir? Regarding SPECT scan, which is cost effective? When will be the indication for SPECT in dementia?
So the thing is, SPECT is definitely way cheaper than PET if you're looking at it from a commercial rate wise. And but the information which you get, the resolution is of PET is much better than SPECT. That's because SPECT is around the resolution is around the thickness, slice thickness. What we're taking is 5 mm, whereas in PET we are taking 1 mm. So when it comes to brain, the spatial resolution should be very high to pick up subtle dementias. Like it happens at the sulci level or the gyri level. So definitely we have migrated from SPECT to PET. But in Tier 2 and Tier 3 cities, they may still be using SPECT because of its cost effectiveness and easy availability.
So I think to answer your question as to when is it indicated, so any functional imaging, because there are 2 kinds of imaging. One is structural imaging, second is functional imaging. SPECT or molecular imaging, SPECT and PET scans are belonging to that category. So the role of this imaging is to help in subtyping. Say before the amyloid imaging, we used to do FDG PET. There's another kind of PET scan that can again help in identifying which portion of the brain is affected, which portion of the brain is preserved. So based on that, it is slightly more sensitive than MRI. In MRI, we see that which portion of the brain is shrunken, which portion of the brain is preserved. The same way, functional changes that is seen in SPECT and PET. So using that, we try to subtype, but that subtyping is not a very, very specific subtyping. That information also based on that what we diagnose is not considered as a gold standard. For example, for Alzheimer's dementia, we expect a particular kind of imaging abnormality in PET and MRI. But there may be people who have Alzheimer's, but in a different stage of illness, they may not have a clear abnormality suggesting the subtype what we expect in most of the patients. So it has a limitation compared to amyloid. Amyloid is something which is very specific for Alzheimer's disease. So that is the most established evidence, and which indicates that there is amyloid positivity is there. And if amyloid positivity is there, that means Alzheimer's pathology is there. So that is much more specific than either FDG PET or SPECT. But still, when places it is not available, where because Alzheimer, even in our center, amyloid scan, we've just started now as a research. So we use whatever is available, whatever is feasible, based on that to come at a clinical diagnosis and then treat. So I think the next question is also related. Shweta has asked about MRI is normal, but symptoms are evident. How do you interpret this to determine the dementia, type of dementia? So when MRI and the symptoms are matching, we get more confidence in establishing this conclusively. If MRI and symptoms are not kind of matching, if the MRI is normal and still symptoms are there, still we'll diagnose, but the confidence level will be little lesser. Okay. So the diagnosis of dementia and subtyping is taking together the clinical profile, including MRI and imaging evidence, whatever the best possible other biomarkers, whatever the other investigation we check, putting together, the clinician arrives at a consensus diagnosis. We don't diagnose based on one blood test or a one scan, just by, it is not as simple as say maybe diabetes, like you do a blood test, okay, if it is above a particular level, diabetes is there. So we don't really look at symptoms, whether it is, they should have the symptoms or not. The diagnosis is purely on biomarker. So in dementia, it has not reached that state where we are diagnosing purely on biomarker. It is still has to kind of keeping both the clinical information and the biomarkers, including imaging. Hope that answers your question, Shweta.
Also, I would like to add that when a dementia case is referred first as a first line as CT and then MRI and then amyloid, basically what we are doing is there any organic cause? Like in India, there's a lot of diabetics and hypertensive. So there could be a hematoma or a SDH causing dementia. So any structural lesion, if it is causing dementia, then it becomes an organic, there is some other reason for dementia noted. So only when MRI is normal do we go ahead with such high-end diagnostic tests such as FDG PET and amyloid PET.
Now, I think Mr. Srivatsa has asked an important question. Anybody around 70 years of normal health can take this test to know healthy? Definitely no. So we don't recommend normal people to say that, okay, we want amyloid scans to show that our brain is healthy. No, this is in normal people, they do it as part of research. Healthy volunteers, they do it as part of research to see that, okay, what is the risk, what is involved in normal people when they have amyloid deposition? Do they develop dementia or not over a period of time? To study that, they do as a comparison group, they take it. But clinically, there is no reason of any age, somebody is normal to take any test to check whether their brain is healthy or not. Only when there is a reason to evaluate for a complaint of a cognitive problem or a behavioral change, you need to get a scan done. Otherwise, a person who has a brain which looks like Alzheimer's dementia could have been normal clinically, and a person who does not have that much atrophy in the scan can have symptoms. So these are not something like where you can diagnose just based on scan alone. Hope that answers your question, Mr. Srivatsa. We don't want to.
Sir. Yes, sir, I know that. Because only to age-related issues, sometimes people will get age means some memory power may be lost, or maybe activity like that 50 years will be less, no? For that, if you as a normal case study is taken, then I can improve or we improve our lifestyles. That's my need of
in research, we do take normal people who have subtle memory complaints also, or they may not have any memory complaints, and then evaluate them as part of research as a healthy control group. If somebody has a reasonably significant memory problems, then only we advise investigations as part of the clinical evaluation. Okay. So that's what we have advised, and the health promotion is something is applicable for everybody. It is not just when somebody has amyloid deposition or a scan is abnormal. Okay.
Thank you, sir. Thank you, sir.
Thank you. Thank you. I think Vicky has asked a question. A caregiver who may be experiencing caregiver stress. Yashwanth, can you address this question?
A caregiver who may be experiencing caregiver stress, who has symptoms of not able to recollect or remember few things like he or she once used to some 4 years ago, and has change in mood, unfolding of emotion due to some trigger during that day. So basically, ma'am, this may be, as in the question itself, it may be due to stress. Stress or emotional or psychiatric problems themselves has a role in human cognition. So when there is too much stress and individual is not able to pay attention, it affects their attention as well as memory also. So we have to first address that is stress handling their other activities. So when that is reduced and there is no, if the cognition improves or not, which will be assessed in the follow-up, later we can see whether there is need for any further evaluation.
So the question is about whether the caregiver needs screening or not. Say many of the caregivers are also elderly. If somebody is an elderly person and then they have problems and change in personality, if it is not done, if it is few days or 1 or 2 weeks, usually if it is kind of very significant change is there, and if it is persistent for few months, then only this is something like where the suspicion of cognitive decline and dementia is something considered. So on an individual basis, you should consult a doctor, and then based on that, the screening for MCI and then whether further requires amyloid imaging can be discussed. If it is MCI, definitely amyloid imaging can be considered.
So if the question second part also says like screening of MCI, and then if it is confirmed, yes, if it is confirmed, this study includes MCI, Alzheimer's dementia and FTD. If any of these diagnoses are confirmed, these people can apply for this study using the contacts given.
Yes.
Okay, noted. Thank you very much, sir.
And the individual should be greater than 40 years.
Yeah.
Okay.
It depends on the need. Yeah. The next question is Ravi has asked difference between amyloid and FDG PET. I think already we discussed this. So amyloid is a specific diagnosis for Alzheimer's. FDG PET is to look at which region of the brain is having hypermetabolism. Sandhya, Dr. Sandhya, you want to add anything further?
No, sir. That's it.
So these are both having a place in kind of understanding this diagnosis, and then whether it corroborates or something like that, we'll use it. So Gayatri has asked if there is any specific genetic mutation which can diagnose and predict the occurrence of FTD. Now, the role of genetic testing is something where if somebody is having very early onset of illness, say in 40s or 50s or early 60s sometimes, or if there is a family loading, multiple people in the family are having these problems, mostly their parents or siblings. In both these conditions, one might kind of think about a genetic testing. It is available these days. NIMHANS also has genetic testing where we do a whole exome sequencing, or there are specific genes which are of risk is being done. So for example, for frontotemporal dementia, there is one particular gene called C9orf72. That is a mutation which is tested specifically for that. So that particular test is not available as a clinical test at this point of time in NIMHANS, where it is being done as part of research study. But some other genetic labs in Bangalore also have this kind of facility, and they are able to do this. But most of the genetic tests, which are fairly rare, where which contributes to dementia by itself, what we call as autosomal dominant gene mutations in for Alzheimer's dementia, they are also tested in the scan, in the genetic test what we do. So these are tests ideally done based on genetic counseling, and we don't recommend genetic testing just like other blood tests. So you need to understand, particularly if there are somebody, the family member who is healthy, wants to test, it has a serious implications. So we don't recommend that as a routine test at all, and particularly for people who are healthy. So it should be discussed with the doctor and what are the implications, when to test, what to test. According to that, one has to do it.
Okay. Okay, sir. Thank you.
So I think we have addressed these things. Blood biomarkers. Blood biomarkers, I think already we discussed. There are several blood tests are done. Some of them specific for Alzheimer's disease also are available. Or some things which is specific for neurodegeneration. They are not specific for Alzheimer's, but it confirms that there is a neurodegeneration. Those things are also available. But as of now, we are still in the process of including that as a clinical test. Soon in NIMHANS, we may have a facility to do it as a some of the markers which indicates neurodegeneration is kind of going to be available as a commercial basis. It has been approved, but still we are in the process of incorporating it. It's called as phosphorylated tau1, which is specific for Alzheimer's, and other one is neurofilament light chain, serum neurofilament light chain. We use this when something like, because people with depression can have a cognitive impairment, and sometimes it may be. So to corroborate whether there is a significant neurodegeneration or not, these markers along with scans can be helpful. So there is a place for using these tests also when we have diagnostic confusions. So all these things add up to the clinical diagnosis, what we make, taking everything into consideration. Okay. So yeah, I think recording, we will do the needful. We'll see as to how we can share it in the YouTube channel. We will make some this thing available. So that's answer to Mamta. And Sagar, I think it's a big question. Yeah. Yashwanth, can you read the question?
Yes, sir. So for my father, age 66, history of cholesterol and BP. We did PET scan. After MRI showed some shrinkage. PET scan suggested some scarring in the parietal lobe, etc., which the final diagnosis of logopenic variant of PPA was done. This also matches with the core symptom that we see. It's been just 2 years since we felt the first sign of some behavior changes. Should we go for the amyloid study? What more can we know and impact on the solution?
I think it's a very, very detailed question, Mr. Sagar. One thing is that, as you told, primary progressive aphasia, one of the variants is logopenic variant, and that again is linked to Alzheimer's many times. And primary progressive aphasia are usually frontotemporal dementias, one of the types of frontotemporal dementia. So in our study, we try to distinguish between Alzheimer's and frontotemporal dementia. So we can include as part of amyloid imaging scan study, but we need to do the clinical evaluation and then we need to see that. And regarding, because by doing amyloid scan, it can help in understanding whether the contribution of amyloid pathology or Alzheimer's pathology is there or not. So that is something which will be one of the possibilities. In terms of solution, there is no specific treatment for primary progressive aphasia as of now. It is both in terms of speech training and cognitive training and behavioral management. We are trying brain stimulation. I think in some of the earlier session we might have discussed transcranial direct current stimulation. I think which Yashwanth also had talked about it as some of the. Yashwanth, did you talk about it in the presentation?
No, sir. No, sir.
We haven't talked about in this presentation, but this is something which again in our center we do evaluate that as a potential treatment to improve the brain plasticity. It's called transcranial direct current stimulation. That is available, and one of our colleagues is doing research specifically on primary progressive aphasia. If you are interested, we can evaluate and then we can consider recruiting for that.
Okay, sir. So the phone number that is mentioned, is that the number to coordinate?
Yes, you can reach out to the geriatric clinic through that. I am available. Once you get into them, and then you can come and meet us. Then we can discuss, and then we'll review the diagnosis, and then we can take it forward.
Understood. Okay, thank you.
Okay, I think we had a very active discussion, lots of questions. So I really appreciate the kind of active participation. So we can conclude. Hopefully, we can conclude. Sandhya, thank you very much for your time. I think, and thanks to all of you for participation, and thanks to Yashwanth for making a wonderful presentation. And if any other further queries, please reach out to us.
What exactly is this PET, sir? PET, what is actually, is there any expansion for PET?
Positron emission tomography.
Tomography, okay.
Okay. So I think it's more than 4, so we can conclude. Thank you very much. Kavya, is there anything else? Okay. We can conclude. Thank you very much. Thank you very much.
Thank you very much, sir.
Thank you.
Thank you.
Thanks a lot.